I'm really thrilled to introduce Sue LaVaccare. She's really been a driving force behind the Lesbian and Bisexual Women's Health Collaborative. She actually started advocating in Chicago in the 1990s at Howard Brown Clinic for lesbian and bisexual women's health. She then moved to Minnesota, where she worked with the Department of Public Health on health issues for the LGBT community, as well as women of color. And then she came to Los Angeles, where she's worked both at UCLA and CHLA on lesbian and bisexual women's health issues. So please welcome Sue LaVaccare.
Got it. Hello. I wanted to tell you that this is a model of what we use for training. If you want us to come to your grand rounds or to a meeting, or if you set up a special meeting for us to train you, we have lots of other slides in the deck that we can add and customize for you. We've done these, I've done them in lots of different places, the county, in lots of conferences around the country, and so we can customize this. This is just an example. There's also a whole section in here on health disparities that I'm just going to skip because Patty did such a great job of covering that earlier, and we don't want to be redundant. But I want to acknowledge that today is World AIDS Day, and that's a very important thing to remember and commemorate, and know that we have a long way to go, and we have to keep advocating for HIV and AIDS. And actually, some of my work in the past has been around HIV prevention and care. So just I wanted to acknowledge, didn't want this day to go by without us acknowledging that today's World AIDS Day. There's a few acronyms that were used as well that I wanted to bring up that aren't in here. SOGI was mentioned, the sexual orientation, gender identity. That's a newer term, SOGI data. Sexual orientation, gender identity data. Also, Lambda Legal was mentioned. That's the world's largest legal organization in the LGBT community. And they have a hotline, and they actually have attorneys on staff who work and do cases. They have about a docket of about 90 cases a year to work on LGBT discrimination and HIV discrimination. And that word, Lambda Legal, was talked about a lot. So I just wanted to, I'm here to like sort of clean up. Okay, so we didn't actually define these, and these are just some definitions. There's other definitions that you may have that you prefer, but these are just some definitions to help clarify. Sexual orientation is an individual's emotional, physical, romantic attraction to another person. A gay or lesbian person could be defined as someone who has an emotional, romantic, or sexual attraction to individuals of one's own gender. Whereas a bisexual person could be defined as a person who has sexual, emotional, and romantic attractions or behaviors directed towards some members of more than one gender. Queer is a term that has come back to be embraced and added to the acronym. Historically, it has been used as a discriminatory term. If a patient uses that term, now you'll understand that that's a term that's coming back into use, and you can reflect back to the patient that they use that. I don't know that I would recommend, if you're not part of the community, to use that as the first word you would describe a patient as because of its history, but just that you know that it is used as a term to express being part of the LGBT community. Cisgender is another term that's come into use more recently. This is now moving to the gender spectrum. We were just talking about sexual orientation. Now we're talking about gender spectrum definitions. Cisgender is a term used to describe people whose gender identity or expression aligns with those typically associated with the sex that were assigned to them at birth. Whereas transgender is an umbrella term for those whose gender identity or expression is different from those typically associated with the sex assigned at birth. Gender identity is a person's deeply held internal sense of being male or female, or somewhere else outside the gender continuum. Gender expression is how people outwardly show their gender, and it could be in behaviors or clothing or grooming or mannerisms or speech patterns as a way to express one's gender identity to others. So I'm trying to help decipher and delineate some different definitions for you. So this is kind of what I just brought up. I brought up sexual orientation. I brought up sex assigned at birth, gender identity, sexual attraction and behavior. They're all different concepts. So we have to remember that as we're working with patients that or clients, that gender identity is different from sexual orientation, which is how one is attracted, versus how they identify, and maybe use the term gay or might use bisexual, which is different than their attractions. And I'm going to go into that a little more. So I don't know if that's a little complicated, but on purpose, it's set up to help you to know that we hear one thing about a person, we can't assume everything else. They're different constructs and concepts. So Patty already talked about this. They're everywhere, and lesbians and bisexual women belong to every community, cuts across every spectrum. And there are some transgender people who identify as lesbians or bisexual because gender identity is separate from sexual orientation. And we talked about, I think it was Janet who talked, or no, it was maybe Ellen who talked about the focus groups we did as a collaborative. When I worked at Children's Hospital, we also did, the reason we didn't do adolescent focus groups in our collaborative is because I had just finished conducting 5 focus groups with adolescent lesbians and bisexual and gender fluid young women at Children's Hospital. And so we kind of added that as our 6th group if you look at all the focus groups we did over the last 5 years. And one of the participants said that it's forgotten that we're part of the LGBT acronym. Women in general are invisible, and then you add the attraction to women piece, and we're doubly invisible. So again, a reminder that all of these concepts are different from each other, and so if you hear about someone's relationship status or identity, to also ask about their behavior. And we'll get into a little more specifics of how you can do that. Again, Patty sort of talked about this concept. This is a different study that was a meta-analysis by Williams Institute, and it goes into, again, about how the percentage of women who identify, was based on tens of thousands of surveys that were done with general populations in the United States and around the world. So it's a very robust meta-analysis research. And it shows that 1% of adult females identify as lesbian or gay, which, if you put that in numbers, is a big group. I mean, it's a slice, right, of the larger population, but that's a pretty big potential number of patients. And as Patty pointed out as well, 2% identify as bisexual, so there's much more bisexual identity than there is lesbian or gay identity. So here's where it gets, we just talked about identity. And so in the same meta-analysis, they asked people about their behaviors. And 11.7%, even though 1% identify as lesbian and 2% identify as bisexual, in the last year, almost 12% of those women had some sort of sexual relationship with another woman. And there was different terms and definitions for that, from kissing or et cetera. In a lifetime, which goes back to all kinds of different health practices and health issues, 17.5% of women who were surveyed had same-sex relationships with other women. So again, they identify 1% or 2%, say this is what my label is, but yet when you ask them about behaviors, many, many more times that of women, either in the last year or in their lifetimes, have been sexual with other women. And so that goes back to learning the health history questions, the sexual health questions, and your electronic health record questions in order to get at that information, and just to know that. And just to say that out loud if you don't know that already, so that if somebody does bring that up to you, or if that comes out in your really great line of questioning, that you're not surprised or you're not confused, that now you know that it's a possibility that if something's not adding up, like you're trying to figure out what's going on with the person, this could be a possibility. And so now you know that. So now you can't ignore that or pretend like this is not a piece of what might be going on with someone, if that makes sense. But if you never heard it before, you might not, you're like, I don't know what's going on. Now you know that this could be one of the reasons or one of the issues going on for your patients. So talking a little bit about discrimination, again, was already discussed, but people are less likely to come in for services, either out of fear of being discriminated or a history of being discriminated with their doctors or their providers. And they're also less likely to have a regular source of health care because of that, right? Because the relationship doesn't feel trustworthy or validated, and so they don't really have a provider, and so when they do need help, they just don't go. Does that make sense? Could be for anything, a cold or whatever. All right. I'm trying to look at stuff because we went through a lot of these things, and I don't want to be too redundant. So this is a good little piece, is that the stigma that's felt by lesbian and bisexual women is that 34% of LGBT physicians have reported observing discriminatory care of patients. So there was a survey of providers, and they have observed with their colleagues that they discriminate against patients. And again, someone asked about religion too. This kind of brings up the point, is that as providers, if you start to now reflect on, okay, this is part of every population, right? So we know that there are lesbians and bisexual women, there are women who have sex with women. Now that's part of our potential patient pool. And so part of your job as a provider is to help them be healthy, stay healthy, get healthy if they're not healthy right now, right? And so it's working on that yourself and doing self-reflection outside of that exam room or outside of that front desk or that call center to work on who am I as a professional versus what are my personal beliefs. And this really it talks about if you drug use or sex. You brought up the Irish Catholic, like sex before marriage, whatever. You might have morals and values about lots of things, but your patients come in that don't match with what you believe, but you're a professional. And so your job is to treat that patient in the best way possible. So here's some more quotes that we got from our focus groups, is that the eyebrows go up and it feels like a judgment when I tell them that I'm attracted to women. They look confused when I say I'm attracted to women. I don't really want to tell a person with a needle in my arm that I'm attracted to girls. It's none of their business. So what are we seeing here? We're seeing, like, what's the appropriate time to be asking those questions, being sensitive about what you might think. You might think, oh, I'm just so progressive. I can talk to them about these things while I'm doing, the blood draw. But for them, it's still scary. So you have to be sensitive about when. And also your verbal cues and what you're doing with your physical self is very important, because people are hypersensitive coming in. They're already worried about trust and care, and so how you present is very important. So I'm going to skip this whole section, with just a general overall of health issues that was covered very nicely by Dr. Patty Robertson. Okay, let's see if I get... this is one quote that I wanted to bring in here, though, is that is an example of, this is 2015, right? Every Affordable Care Act and everything's San Francisco. This is a lesbian couple who are highly educated, white lesbians, and they were hypersensitive to finding a doctor they were having a baby. And they found a doctor that their quote was, "He'll be our baby's pediatrician. It's seriously hard to explain how good we felt leaving his office." It wasn't because he was gay. The doctor happened to be gay. It was because he talked with us openly, showed us the rainbow stickers he's placing in all his rooms. He had neutral language on his new patient forms. And for you in the medical field, these very little things to you make a big difference to us, because they're looking for these kind of clues. And this is people who are, like, supposedly in the most privileged communities, and they're still hypersensitive and looking for that trust and safe care. So more quotes from our focus groups is that providers assume that I'm only sexual with my boyfriend, and they don't ask about other partners or other recent partners. And I've been asked if I'm sexually active, but never with who. And I'm asked if I need a pregnancy test every time. So we're going to skip through these. Okay, I had an assumption that my OB/GYN, since she was Korean, so I was kind of hesitant because everyone in the Korean community knows each other, and she's been in the career for 30 years, and so it's a possible chance she knows my mom. So this is kind of a triple identity issue going on. No, and actually this theme came up a lot in certain, not across all cultures or all, but in some of our focus groups, this came out often, is that there was this concern about, again, disclosure and it not being safe to be herself as a lesbian to her community, to her parents, etc. So she had to think about that in her provider choice. And another woman said, I think that coming from the Latina community, where it's still very much looked down upon to be gay, that you're kind of a first-generation lesbian. In most cases, you really have to seek outside medical services. You have to be very careful. So point is that people are coming in with lots of, maybe, I don't know if you want to call it, not baggage, but a lot of lenses, right? And there's apprehension and worry of you accepting them, and therefore their level of being able to disclose and open up is going to be probably hindered, and it's up to you to set up a good environment for them to feel comfortable to give the information that you need. This is more information from our focus groups of our 65 and plus focus group, is they really focused a lot on, and again, it was mentioned earlier, I think by Tari, is that the need for the health care directive was mentioned frequently among the 65 plus focus group. And a lot of them mentioned having difficult and unpleasant experiences when they tried to visit their partners. Here's some quotes. When my partner went to the hospital, I heard over and over again, "Who are you?" And I had an advance directive. And I think it wasn't until the rabbi came to marry us in the ICU that they caught on and said, "Oh, now we understand." These are older women. And I had a lawyer tell me certain things like, always take the directive with you, keep a copy in your car. And this woman was somebody who had one in her file, but it was buried so deep in her file that the doctors and nurses didn't see it. And now that you have EHRs, I'm assuming, and that all depends how you set up your EHRs, if that's something that pops up, and if you have a banner. And those are things we can talk about if we do specific trainings, is best practices on how much room there is with EHRs to rearrange it and how much there's not, and what specific issues are important to your clinic or your hospital. So on intake forms, you should be asking questions about sexual orientation, sexual activity separately, relationship status separately, gender identity separately, and sex assigned at birth separately. And again, there are some best practices EHR forms that are already in use around the country that you can use as a model. And education materials that you have around the clinic office and in each exam room should be inclusive materials that have images of same-gender couples and transgender people of, wide, diverse population. So I like the introductions and some more quotes. So just to give you a sense of what patients are saying is helpful for them. I like the introduction of, is your partner male or female, as a question on the form. It sets the tone from the very beginning. Then the provider can steer their questions that are inclusive to having a male or female partner. I like the idea of the provider inquiring about my sexual orientation or it being a question on the form, because it helps normalize the experience for everybody, whether you or they are comfortable or not. It helps break the stigma, and I think it's the best way because I don't know how to bring it up myself. And that came up a lot too, is that, and this is in research as well, is that patients would prefer the provider to be the one to show the openness, ask open-ended questions so that they know it's safe to come out and share their behaviors or their identity, et cetera, as opposed to putting the burden on the patient who might feel afraid or it's awkward for lots of the reasons we just described in the past quotes. And so there's also things you can do is you can put posters, and you can make them yourself. So we did that at Children's Hospital. We got a couple people to sign releases, and we took some pictures of doctors with patients, and we put them on a poster, and we wrote some words underneath it, and there you go. And you put it in every exam room, you put it in all of your waiting rooms, and you put a non-discrimination clause letting everyone know when they walk in there that everyone is safe being there. This is just one example. So talking about how to interact with your patients, one of the things that I think is really important is we're talking about all these things, is what you should do is communication. It's just basic communication, which is not easy for any of us. Communication is a very difficult thing for all of us. We're always working on it. And if we can work on being compassionate and caring and open and empathetic and respectful of our patients, that goes a long way. By how we look, by how we say hello to them, by not looking at your phone as you're walking in or turning your back to them as you're talking to them. And the way I like to describe it is core. So core communication. So when you put your hand on that doorknob, or when that person approaches your desk, or if you pick up that phone, because that's how you talk to the people, at that moment you engage your core. And with every new patient, you engage, I'm going to be compassionate and open and respectful and empathetic with this person. And that's, you have to figure that out for yourself, like the practice of doing that. So I'm going to give them my 10 minutes of attention. Patty said she has 10 minutes per patient. Well, I'm going to give that person 10 minutes because you want to do a good job. I mean, so you feel good about yourself too, right? You want to be the best practitioner you can be to give them the best services as whatever part of that team that you play. And so that means being completely present for them and being open, respectful, caring, and empathetic. And so, again, it's to help them feel comfortable, to help them feel safe. And another point is we had some feedback about where you're talking to them. So again, remembering that, finish the conversation in the room. And as you're walking out, don't continue that conversation in the hallway. Or if you are in an ER situation, there might be an overload and you're like having a conversation out in the hall on a gurney. Keep that for a private location. Does that make sense? So where there's not other people around. Or if you're with an adolescent, is there time that you set aside to make sure you're talking to the adolescent patient alone without the parent or the guardian there, so that you can have a more safe environment for them to disclose, or even a partner for that matter. Maybe in every one of your visits, you should build in, doesn't matter who's there with them, as you ask for a minute alone with your patient without their advocate there if they feel safe with that, so that there can be that a deeper disclosure opportunity if they want that. And then I mentioned this earlier, is your body language. So be respectful with the words you use, and I know that's very vague, but we're going to try to help you with the things that we're giving you. And we also have some extra questions in your on your, I think, your flash drive that are other examples of phrases you can use to be more inclusive and open and make it safer and comfortable. So open-ended questions are always a safe bet. I know you have to get at specific information, but you can try to ask it in a more open way. And if you need clarification, you can ask that, but again, I'm going to give you a few examples in a minute of how to present to them why you need that clarification. And so being a team player with them as so that they understand why you're being what they might consider invasive, or where's this line of questioning going, or if it's about birth control or pregnancy tests, helping them understand what your rationale is and why you have to do this. So the other thing is we talked about this before, and it's on here again, is that focus on behaviors and not so much on their identity. When they've maybe told you what their relationship status is, and somehow you've figured out their sexual orientation or identity, but you still have to get at what their behaviors are, which is the case beyond sexual activity, right? So here's some example questions. In order to provide you with the best possible care, I need to ask you some questions about your sexual history. So you're just opening it up in order to provide you with the best possible care, to help them know that you're trying to be sensitive, you're trying to be caring. I'm going to ask you a few questions about your sexual health and sexual practices. I understand these are very personal, but they're also important for your overall health. I ask these questions of all my adult patients. Like the rest of our visit, everything we discuss here is confidential. So you can add this at the beginning, you can pepper it in throughout the conversation you're having. And again, it fits in with any role that you have. Again, if you're on the phone or at the front desk or as a provider. And I know that these are sensitive issues, and in order to learn more about what might be causing your symptoms, can you tell me more about ... And in this case, we have if you've been sexual with anyone in any way in the last 12 months. So it's a more open question, right? It's 12-month period, sexual with anyone, sexual in any way, and it opens up more of a dialogue where they might look at you like, what? But then you can talk to them about that, or they're going to feel more comfortable that they can share. Other ways to put something are you dating or in a relationship? Are you currently sexually active? What's the gender of your partners? We just did a training recently, and they were adding transgender on their form, and they had to start gathering that data, and they were like, how am I going to ask that? I'm like, you just ask, what's the gender of your partner? Just like, what's the marital status? What's the date of birth? What's your gender, or what's their gender? And if you make it a regular question, a matter-of-fact question, they're going to answer it that way. And if they're not understanding what the word gender means, then you can come up with some, say, how, like on the form it says, are you male or female? How on your form it says that, what gender is your partner? But most of the time, people who are transgender or are sensitive about, they're hypersensitive because they're afraid. Once you say what gender is your partner, they're going to get that and they're going to answer. And again, at the end, always in the middle, saying, okay, thank you for sharing. This is very helpful and important information. Because we're always rushing and there's a lot going on, and maybe your labs didn't come in or your nurse did not do what she was supposed to just do, and you're out in the hallway and you were upset. But when you're there with that patient, we have to not take that out on them, or if you're behind in your calls or whatever it is being respectful, being open, and thanking them, and letting them know that they are your priority. So what are the things to do? So hi, nice to meet you at first, as opposed to being a little bit more abrupt, making eye contact with them, maintain an open physical stance, a neutral facial expression, present with a personal verbal tone, follow your patient's lead on what they're saying, so you have to really be listening to them, and provide positive affirmations, again, to what they're sharing with you. And you don't want to turn away from a patient when they're talking, if at all possible. You don't want to pull back when they say something that upsets you or confuses you, or stare blankly at them. Or you have to learn and figure out your own physical cues. You may just by nature cross your arms a lot or something. You have to learn that if that's something you do in a defensive mode, you have to work on that and try not to do that. And we already said this with the needle draw, but also with pap smears, et cetera, is when you're doing invasive procedures to not be asking them very intimate questions or sexual activity questions, is to do that when they don't feel as vulnerable. And to not present negative facial expressions, which is hard. I have a lot of facial expressions. That's really hard for me. So here's a patient scenario that is an example of how something might go. So there's a woman named Carmen who comes in. She's 28 years old, Mexican-American woman, presenting with severe abdominal pain, and her last period was 6 weeks ago. And when asked if she could be pregnant, she says no. So the healthcare provider comes in and says, hi, I'm Dr. Brown. So what brought you here today? And Carmen says, my stomach is really hurting me. I feel nauseous sometimes. And Dr. Brown says, is there any chance you could be pregnant? And Carmen says, no, my period has always been irregular. And Dr. Brown says, do you have a boyfriend? And Carmen says, no. And Dr. Brown says, are you sexually active? And Carmen says, yes. And the healthcare provider says, do you use birth control? Carmen says, no. Then we need to do a pregnancy test to rule out the possibility that you're pregnant. And Carmen says, but there's no way I could be pregnant. It's got to be something else. And then the healthcare provider says, what else could it be? You're sexually active, and you're not on birth control, and you haven't had a period in 6 weeks. What am I missing? And then Carmen looks down, and she's quiet. So what could the provider have done differently there? If people want to answer that. Anyone raise their hand and share? Yes? Right. So she said, find out what the gender of the partner is. Yes. Anything else? Yes. Right. So don't make an assumption. Maybe go down and ask more questions because you're a little puzzled, you're not sure, and you can go through some of those phrases like in order to give you the best possible care. And we'll go into that in a minute. Anybody else? Yes. Yep. Good. So not assuming and asking if she has ever had these symptoms before, where they had the nausea and she already said that she has had irregular periods, so that wasn't, but she had stomach pains and nausea before. Very good. Yes.
Not assuming
testing.
I don't know.
Not assuming what's the type of sexual activity she's encountering.
Right. Not assuming what the type of sexual activity is that she's engaged in. Correct. Yeah, that's great. Great. So we've pretty much said those things. She didn't begin with open-ended questions, and she assumed heterosexuality, and she didn't clarify the sexual behavior, and she assumed the need for pregnancies tests and birth control, and she didn't empathize about the sensitivity of the information, and Carmen ended up feeling judged and embarrassed. And what would be the consequences of this, do you think, possibly? Anyone? Yes. You might not want to come back at all for health care. Okay? Yes, thank you. Someone back there have a? That was your same thought. What else? Yes. She didn't get her necessary test. Oh, unnecessary testing, right. So the doctor might then just say, we're going to test you I'm going to give you these labs even though the patient does not want them. And then there's, yes, which has a lot of consequences, right? There's the health insurance people would like to know about that. Yes. Right, so the patient might leave right then, and so the diagnosis doesn't actually happen because we can't follow up to really find out what the issues are. And she's shut down at that point, so she's not going to give you more information. Great. Yes. Absolutely. Absolutely. So the clinician has a narrow vision of what the possibilities are. And that's exactly why we're doing this, is we're not necessarily giving you answers, but we're helping you to see that this is a possibility. And so how you ask the questions to be able to be open-ended and offer a safe, respectful environment, caring environment is very important. So here's a way it could have gone. Just one possible way it could be different is Dr. Brown comes in and says, nice to meet you. What brought you here today? And Carmen says, my stomach hurts. It's really been hurting me and I feel nauseous sometimes. And Dr. Brown says, in order to provide you with the best possible treatment, I need to ask you some questions about your sexual history. Are there any chances that you could be pregnant? It's right there, already framing it like, I know these are sensitive, but I need to ask you, is there any chance you might be pregnant? And Carmen says, no, my period's always been irregular. And have you been sexual with anyone in any way in the past 12 months? And Carmen says, yes. She says, I know these are sensitive issues, and to learn more about what may be causing your symptoms, can you tell me more about him or her? Carmen says, I'm dating someone and we're having sex. So still not really giving you the information, right? So Dr. Brown says, okay, what's his or her name? And Carmen says, her name is Joanna. And Dr. Brown says, thanks, what gender is Joanna? And Carmen says, she's a woman. I mean, technically, we could go down that line and say she's a woman and she might be transgender. That's true. But I mean, I think you're going to a point where you're asking and open-ended enough that I think most people who are in that situation will see you as safe and will be able to then disclose that information. And so then the provider says, okay, thank you for sharing this. It's helpful information, and I want to hear more about how things are going with Joanna after we figure out what's causing your stomach pain and nausea. Have you been sexually active with anyone else in the past 12 months? So again, not just assuming that that's the only partner that she has. And Carmen says no. And so again, the doctor one more time checks in and says, okay, from what you're telling me, it sounds like you haven't been sexual with anyone besides Joanna, including men in the past 12 months. Is there anything else you want to share? Or are there any questions you have before we go on? Because sometimes now the person has come out and like, okay, I'm a lesbian, I have a partner, and what if she did have sex with a man? And this gives an opportunity to say, I know that's still a possibility, but I'm not doing it in a way that says you probably did. It's just a kind of open-ended way to still get that in the summary. And the person's like, wow, this person is really understanding and open, and I can now say, well, you know, that did happen, or no, that's great. Wow, what a wonderful provider. I feel really safe here. So it still gives that one last loop because pregnancy tests are important for a lot of tests, right? So you want to know if a person's not pregnant before you do a certain tests that would possibly harm the pregnancy. So again, Dr. Brown started with open-ended questions, and she didn't assume that Carmen was heterosexual. She clarified the gender of the sexual partner. She explained the need for why she needed to ask those questions. She didn't assume the need for birth control.
Okay, thanks. Bye-bye.
I think Julie has a microphone allow, allow for additional disclosure and questions. And don't assume that Carmen, she didn't make Carmen feel judged or embarrassed. And so Carmen is more likely to confide in her, give more information, and return for further care, either to Dr. Brown or to other providers in general. Because you may be the frontline person, even at the front desk, and something happens, and not only have you turned them away from your clinic, you may have turned them away from service in general because they've had that experience before, and now it's like, oh my gosh, this happened again. I tried someone new. So on the flash drive, there's a lot more potential questions that you can use that are best practices, and questions that you can put on your EHR form, and statements that you can do. And that's really all I have to say, because these lovely ladies said a lot of what we would normally do in a training. So we have lots of resources. Someone asked about resources, and on the I'm looking at you, Janet, because on the UCLA Iris Cancer's website, we have put just, I don't know, hundreds and hundreds of article references for you to look at if you want to go and look at the literature, and also these references to websites that are government websites of things that Tari referred to, of what currently exists in terms of policy. Yeah, so everyone, if you don't have one of those flash drives, we have one for you. I think we got it around to most tables, but they should have been at your table. And so that's where these presentations are, as well as there's extra resources on those flash drives. Great. Thank you very much.